This episode is sponsored by our global research partners. Want to contribute to the advancement of medicine? Make some easy money while sharing your thoughts with market research surveys. Learn more and sign up using the special TFOC link on our website and in the description box below.
Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our colorectal cancer journey, this time talking about metastatic colorectal cancer. Guys, we finally made it to this point. There's a lot of information to get through in these last episode or couple of episodes, but really important information for our listeners to learn, both for the boards and also clinically. So I'm excited to get into this for sure.
Yeah, it's going to be a great episode. We're going to walk everybody through why we use bevacizumab, when do we use EGFR inhibitors, and the historical data that got us up to here, which really allows you to understand treatment breaks and treatment holidays and the data behind those things.
That sounds great. Well, then without further ado, let's roll that show. I've been waiting for us to start recording because I wanted to share some exciting news. After 3 years of living in the South, I finally got my first pair of cowboy boots this past weekend, y'all. I'm super amped. I got them branded. I can't wait to rock them to clinic tomorrow.
Ronak, so you're leaving the South forever, literally indefinitely. You're never going to come back down here. And you bought cowboy boots at the end to wear in Philly?
My goal is to let people know that they hired the Southern one when I walk into the hospital on my first day. So I want to take part. I want to bring a little bit of this Nashville culture with me up to the city of brotherly love of Philadelphia. Maybe if I see you guys around, you'll get to see me rocking them. I wear them everywhere now.
You're going to be that guy, Ronak. You're going to be that guy, which is fine. But, here we are.
The boots will be my whole personality.
I'm sending you a Grand Ole Opry belt buckle. You're going to have to put them together.
Slightly less interesting than my new pair of boots is metastatic colorectal cancer. And so I'm really amped to get into this. And so without wasting too much time, guys, why don't we just jump into this case? Because we got a lot of data to get through.
All right. So we have a 56-year-old female who presents for management discussion of a newly diagnosed metastatic colon cancer. She initially presented for workup of a 30-pound unintentional weight loss over 4 months with progressive right upper quadrant abdominal pain. Her labs were notable for elevated transaminases and a new microcytic anemia. She underwent a colonoscopy and had a biopsy for a sigmoid mass, which was consistent with a poorly differentiated colon adenocarcinoma. Staging CT imaging showed multiple bulky hepatic metastases in bilateral lobes, a right adrenal mass, and multiple peritoneal implants concerning for metastatic disease. She underwent a CT-guided biopsy of the hepatic mass, which confirmed metastatic disease. The pathology showed poorly differentiated colon adenocarcinoma that was microsatellite stable and HER2 negative by IHC. Next-generation sequencing showed BRAF wild type, KRAS wild type, and NRAS wild type. She had a CEA drawn that was elevated at 250. So there are so many critical details we need from the pathology reports to guide treatments. We're now in an era of molecular targeted therapies, at least for a subset of our colorectal cancer patients. So can one of you go through the general approach for a patient with metastatic colorectal cancer?
Yeah, there are a few important things to consider when you're seeing a patient with metastatic colorectal cancer. You first need to classify if this is limited or widely metastatic disease. Some patients with limited or oligometastatic disease can actually be treated with curative intent, which is sort of an unusual thing in the metastatic cancer world. Synchronous metastatic disease in the liver, meaning found at the same time as diagnosis, happens in about a quarter of patients, and most patients in that group will have sort of isolated liver metastases. There are another 10 to 15% of patients who have synchronous pulmonary metastatic disease. This distinction of oligometastatic disease is a moving target, but generally up to 5 liver or pulmonary metastases could be considered resectable and treated with curative intent. So these patients need to be presented at a multidisciplinary tumor board so you can kind of make those plans, see what you can potentially achieve. And it's important to know that 5-year disease-free survival rates with resection or radiation of metastatic disease in these sort of highly selected cases is around 20 to 40%, which in the metastatic world is pretty remarkable. Limited metachronous metastatic disease, meaning that the disease recurred after initial curative intent treatment earlier on, can also be treated in a curative manner, assuming it fits that same criteria of just a few spots in the lung or liver. Next, we need to know if the tumor is right-sided or left-sided. Which side of the colon did it originate? So right-sided is the cecum to the splenic flexure, and left-sided is the splenic flexure onward. And last, we need to know the MSI status, HER2 status, BRAF status, and RAS status. This molecular information can come from next-generation sequencing, and we can do that to get the BRAF and RAS status, but individual molecular panels can also be sent for other specific mutations if they're not included in your panel.
Dan, that was a great recap. And I think if we remember anything from this discussion, it's that these patients are complicated, and we really should be presenting patients with limited metastatic disease at tumor board to really determine the best way to undergo curative intent treatment. So our patient, from what Vivek described, has widely metastatic disease. Her tumor is left-sided, and the tumor results suggested that the tumor was microsatellite stable, was HER2 negative, was BRAF wild type, and was both KRAS and NRAS wild type. As we go through this episode, it will become clear that treatment of these patients has evolved to more targeted approaches, which is why this testing is so important and definitely something to remember in the upfront diagnostic setting. So let's focus on our patient who has unresectable metastatic disease with palliative intent treatment. What were some of the pivotal historical studies that led to our general paradigm for treatment of these patients? And of course, our resident historian, Vivek, I'm going to turn this question over to you.
So 5-FU was developed in the 70s. And from the 80s to 90s, 5-FU with leucovorin was the standard of care for patients with metastatic disease. And during the time, there was actually a very questionable survival benefit with that approach. So patients really probably had minimal benefit compared to just best supportive care. In the 90s, both the topoisomerase inhibitor irinotecan and platinum agent oxaliplatin were tested in combination with 5-FU and leucovorin with promising results. There was a phase 3 randomized cooperative group trial run around that time of the 90s that compared infusional FOLFOX4. The 4 here refers to a lower 5-FU and oxaliplatin dose versus bolus 5-FU and irinotecan versus irinotecan and oxaliplatin combined without 5-FU in the first-line metastatic setting. That study found that FOLFOX was superior in overall survival, and it also really showed us that infusional 5-FU is the way to go. So not bolus 5-FU with irinotecan, not irinotecan plus oxaliplatin. So that really led a groundwork to a few really, really important studies. And one of the most important studies was another phase 3 trial that informs standard of care for most patients today that was run from 1997 to 1999 in France and Belgium. And patients with metastatic disease were randomized to FOLFIRI until progression or toxicity, followed by FOLFOX or the opposite sequence. So again, we're using these infusional 5-FU regimens. So it's not the same as that 5-FU bolus with irinotecan. So really FOLFIRI or FOLFOX first, and at progression, go to the other one, which is the better approach. And really, there was no difference in the two arms. And it's important to note that these patients got FOLFOX or FOLFIRI until progression, then switched to the other one. So it's not really what we do today where we drop the oxaliplatin or irinotecan and go to 5-FU maintenance. But it did really inform us today that this approach, that this idea that FOLFOX or FOLFIRI first doesn't really matter, and we should have an individualized discussion with the patients on toxicity. And the side effects that were notable in the irinotecan arm, they had more alopecia and diarrhea. In the oxaliplatin arm, they had more thrombocytopenia and neuropathy. So we're basically asking our patients, hey, look, what's more important to you? I'd rather not lose all of my hair. And that's very reasonable. And they may really not like the GI side effects of diarrhea, whereas you might have a musician that says, I don't want neuropathy. I need to play the piano or the guitar or whatever. And that can kind of help you determine whether you want to do something like a FOLFOX or FOLFIRI first. And then lastly, and we'll link a bunch of this stuff to our show notes. Remember, all of this will be there. There were multiple efforts done to really understand if CAPOX and FOLFOX were the same. And bottom line, through randomized trials and a meta-analysis of 8 studies, there was no difference between CAPOX and FOLFOX. They can really be used interchangeably. And when you think about it, what about capecitabine and irinotecan? Didn't work because of overlapping toxicities with diarrhea.
Okay, so for our metastatic patients in the early 2000s, we had equipoise, choosing FOLFOX, FOLFIRI, or CAPOX in that first line setting. You mentioned in the study looking at the sequence of FOLFOX or FOLFIRI that patients receive chemotherapy until progression and there was no maintenance therapy, which is now our standard of care. Also, giving a patient 6 months of oxaliplatin in a palliative intent setting seems a little extra. We currently treat our patients with something like FOLFOX for 3 months, followed by 5-FU maintenance, and then at time of progression, we'll switch to FOLFIRI, followed by, again, maintenance after 3 months of FOLFIRI. We'll get to the use of bevacizumab and EGFR-directed therapies, these targeted therapies, soon. But what's the data behind early discontinuation of the more toxic therapy, oxaliplatin or irinotecan, followed by continued 5-FU maintenance?
So as Vivek just mentioned, the sequence of FOLFOX and FOLFIRI didn't really matter. And as we've talked about before in the metastatic setting, therefore the shift became to optimize quality of life while still trying to maintain efficacy. And, if you haven't done so already, please do check out our adjuvant episodes where we really go into a deep dive in the data on the long-term neuropathy issues with oxaliplatin if you haven't listened to that already. And we also talk about this in our pharmacology episode as well. So the same group that looked at the sequencing question also tackled the idea of de-escalation, which was published 2 years later in 2006. So this was a phase 3 randomized control trial called OptimoX-1, which is kind of clever because you're optimizing oxaliplatin use. So patients were either randomized to FOLFOX4 every 2 weeks until progression versus FOLFOX7, which is a higher oxaliplatin dose, and that was every 2 weeks for 3 months. And this was followed by 5-FU maintenance every 2 weeks for 6 months, followed by FOLFOX7 again for 3 months. And there was no difference in progression-free survival or overall survival outcomes, which showed us that a stop-and-go approach is reasonable for these patients and also showed that retreatment with FOLFOX is reasonable if it was discontinued to prevent toxicity as opposed to progression. There was also less grade 3 or 4 neuropathy despite oxaliplatin dose at 85 milligrams per meter squared in the continuous arm versus 130 milligrams per meter squared in the FOLFOX7 arm. And there was a subsequent phase 2 randomized trial called OptimoX-2. And in this study, patients were randomized to FOLFOX7 for 3 months, followed by 5-FU maintenance for 6 months, and then retreatment with FOLFOX7, like in OptimoX-1, versus FOLFOX7 for 3 months, and then reintroduction only at the time of progression of disease. So in other words, 5-FU maintenance was followed by retreatment versus no maintenance followed by retreatment. The primary endpoint was duration of disease control. And the arm with the 5-FU maintenance had statistically significant improved duration of disease control by 3 months. And the median chemotherapy-free interval in the no maintenance arm was 4.6 months. There was no difference in overall survival, though we note that the study was not powered for this finding. And so given the improved disease control, 5-FU maintenance was solidified as the standard of care for these patients. A similar study was also used to evaluate FOLFIRI, and they gave it for 3 months, followed by discontinuation and retreatment at progression versus continuous FOLFIRI, and they showed essentially the same results as the FOLFOX study, and we'll link those in our show notes. And there was also another subsequent meta-analysis looking at our randomized controlled trials from 2000 to 2014 of intermittent versus continuous oxaliplatin or irinotecan use that confirmed the non-inferiority intermittent therapy followed by 5-FU maintenance.
Let's take a moment to learn more about the sponsor for today's episode. Imagine there was a way you could use your expertise as a healthcare professional to contribute to medicine, to improve the patient experience, and help impact the development of new drugs and devices, all while making some extra money.
We have the solution. Market research surveys through our partners, M3 Global Research, All Global Circle, and M Panels. Through their easily accessible and secure platforms, you can complete market surveys on your own time. It's the perfect way to make some extra money while making a difference. It's so easy, and we couldn't recommend it more.
To learn more and to sign up, use the special TFOC link on our website, thefellowoncall.com, and in the description box below.
That makes sense for why we use intermittent as opposed to continuous approach of therapy. It also tells us that we can retreat patients with a prior regimen and still get some degree of response. But let's get back to our patient. So she has a left-sided tumor in the sigmoid with metastatic disease at the time of diagnosis. We're planning to start FOLFOX and panitumumab, given that she has left-sided KRAS, NRAS, and BRAF wild-type metastatic disease. The natural progression in oncology is to add drugs to our standard of care backbone. And in the metastatic setting in colon cancer, we have these targeted therapies. So what's the deal with anti-VEGF bevacizumab, and anti-EGFR therapies, cetuximab and panitumumab.
So let's start with the bevacizumab story. When we think about these agents, so again, VEGF, the vascular endothelial growth factor, was found to be an important regulator of both normal and pathologic angiogenesis. There was a humanized antibody called bevacizumab that was developed to block VEGF, and the thought was that it could be used in cancers to both block angiogenesis and alter the tumor vasculature to allow for optimal chemotherapy delivery, so kind of a twofold reason why to use that with chemotherapy. Initially, there was a phase 2 study that combined bevacizumab with 5-FU monotherapy, which showed improved response rates and overall survival. There was a subsequent phase 3 study that showed the addition of bevacizumab to bolus 5-FU and irinotecan also had improved overall survival, and we'll link both of those to our show notes. That study with bolus 5-FU and irinotecan was published in the New England Journal in 2004. But the key thing to know, these aren't infusional FOLFIRI regimens, right? That was a totally different regimen that was inferior to FOLFOX. So then the question became, what about adding bevacizumab to FOLFOX in the frontline setting? And there was numerous RCTs looking at this question, looking at FOLFOX plus bevacizumab versus FOLFOX plus placebo. The largest study that we want to highlight was published in the JCO in 2008. It included 1,400 patients that were randomized to either CAPOX or FOLFOX, followed by a second randomization to bevacizumab versus placebo. The co-primary endpoints were non-inferior PFS of CAPOX to FOLFOX and also a superior PFS of the bevacizumab versus placebo. So it was answering a couple of questions. There was no difference between CAPOX and FOLFOX, as we've previously discussed, no difference between those two regimens. But when we looked at the bevacizumab, FOLFOX or CAPOX plus bevacizumab had statistically significantly improved PFS by a mere 1.4 months compared to FOLFOX or CAPOX alone, a very minimal improvement in PFS. And there was interestingly no difference in response rates between the two groups. So if we're thinking about, is this allowing for better chemotherapy delivery? I don't know if we can necessarily say that. And most importantly, there was no statistically significant difference in overall survival. One criticism that people note is that only 30% of patients continued bevacizumab in maintenance. So some think that maybe it's the bevacizumab in the maintenance setting that really gives us this improved overall survival. Nonetheless, this was only a very modest improvement in PFS with a combination in the frontline setting. So then we're asking, what about bevacizumab in maintenance? And there's a trial done by the Dutch Colorectal Cancer Group that everyone needs to really know about to understand the role of bevacizumab in maintenance, and this was called the Cairo 3 trial. All patients got CAPOX plus bevacizumab in the front line, and they were randomized to capecitabine plus bevacizumab maintenance versus placebo, so no maintenance at all. And this was followed by retreatment with CAPOX plus bevacizumab at progression. So everyone should really understand that these studies all had retreatment with the prior regimen. This will make sense when we talk about the very later lines of therapy at the end of this episode. The primary endpoint here was PFS2. PFS2 was significantly improved by roughly 3 months, and there was no difference in overall survival. So again, we're getting this PFS benefit with 5-FU maintenance, but no difference in overall survival. This study really led to a more standard use of 5-FU with bevacizumab in maintenance in the United States, not necessarily in all of the European countries. But again, one big issue here is that there was no overall survival benefit, and you could say, well, it was underpowered, but if one existed, it would likely be very modest. The other unanswered question is, what if the patients had 5-FU monotherapy maintenance and switch to FOLFIRI, right? We're retreating them with the same regimen. What if we did what we actually do in current standard of care practice? Would the bevacizumab really make a difference? And the last thing to note is that first-line therapy with bevacizumab plus oxaliplatin doublet didn't really improve outcomes, so we might be over-treating patients by giving it to everybody in the front line. You might be able to argue to give it maybe in the 5-FU maintenance setting, but to give it to the oxaliplatin patients in the front line may be over-treatment. And last thing we want to note is there's a study to highlight that. It's a meta-analysis of 6 randomized trials in the frontline setting of bevacizumab in combination with chemotherapy for metastatic colorectal cancer, included over 3,000 patients. In the whole population, there was a very slight improvement in PFS and OS, and really it was only in those who received FOLFIRI plus bevacizumab. The patients who received FOLFOX plus bevacizumab had no benefit in PFS or overall survival, and the highest level of evidence meta-analysis of randomized studies. So it really tells us that to summarize all of this, there's a very modest benefit on the order of 1 to 3 months when we're thinking about using 5-FU in the maintenance setting and combined with FOLFIRI. And there's extremely weak randomized trial and meta-analytic data to support the use of FOLFOX plus bevacizumab in the frontline setting with a PFS benefit of a mere 1 month.
So, although we utilize bevacizumab frequently in the frontline and the maintenance setting, it's important to understand that the benefits were very modest, as Vivek's pointing out. Some people actually choose not to incorporate bevacizumab with FOLFOX and start it in the maintenance setting and with FOLFIRI based on the data that we just discussed. So our patient was planned to get anti-EGFR therapy. One of the things that Dan had mentioned when he was doing the introduction was this thing about left-sided versus right-sided tumors and RAS mutation status. Why does any of this matter?
So colorectal cancers often have EGFR overexpression, right? These are epithelial cells, so they have the epithelial growth factor receptor, and often they can grow by overexpressing it. As a result, we came up with these EGFR inhibitors or anti-EGFR antibodies. We thought this would be a good strategy because these cancer cells seem to be reliant on the EGFR pathway for their proliferation. You can check our show notes for a diagram of this pathway, but to simplify, EGFR is the most upstream target, and it then activates RAS, which activates BRAF, and sort of leads to all the genetic expression that results in cell proliferation. This means that if there's a mutation in RAS or BRAF, then there's no advantage to blocking EGFR because it's upstream of those two potentially mutated signaling molecules. That pathway will still be constitutively activated whether or not there's EGFR overexpression. RAS wild type and BRAF wild type are predictive biomarkers for response to EGFR inhibitors because of that, right? So if there isn't any constitutive activation of the pathway downstream of the EGFR receptor, then potentially blocking the EGFR receptor would actually have an effect on the underlying pathway. There were early studies looking at the use of cetuximab combined with chemotherapy or as a single agent in the metastatic setting. Pooled analysis published back in 2008 in JCO showed that patients with RAS mutations did not derive benefit from EGFR inhibition, while those with wild-type RAS did. So there was a 0% response rate in patients with a RAS mutation and a 40% response rate in those with wild-type, which is a pretty striking absolute difference. There was also an important cooperative group study with the CalGB and SWOG groups. So CalGB SWOG 80403 included patients with colorectal cancer and KRAS wild type, specifically in codons 12 and 13. This study, we'll want to point out, did not include extended KRAS, NRAS, or BRAF testing that we mentioned earlier is really, really important now that we know about it and we're able to do it. So a caveat to this study. And all patients got either FOLFOX or FOLFIRI at the discretion of the treating physician. So they're a dealer's choice on which regimen. And then they were initially randomized 1:1:1 to add bevacizumab, cetuximab, or both bevacizumab and cetuximab. The combination of chemotherapy plus bev plus cetuximab was generally found to be too toxic, and so that arm was actually halted early. Patients were then randomized, sort of going forward, 1:1 to either adding bevacizumab to the dealer's choice regimen or adding cetuximab. In the overall population, there's no difference in progression-free survival or overall survival. In subgroup analysis, though, those with left-sided tumors had significantly improved PFS and OS with chemotherapy plus cetuximab compared to chemotherapy plus bevacizumab. The OS difference was 37 months versus 32 months. In right-sided tumors, bevacizumab was superior to cetuximab, with an OS of 24 months versus 16 months. We'll have links to both the subgroup analysis and the original trial publication in our show notes for if you want to review that further. After this study, there's a trial design in Japan called the Paradigm study. That was just published last year, 2023, in JAMA, to look specifically at left-sided RAS wild-type patients with colorectal cancer. Patients were randomized to FOLFOX plus BEV versus FOLFOX plus panitumumab, one of our other EGFR antibodies. All patients had extended RAS testing done to confirm wild-type status, so it covered all those other variants that we had discussed. And there was improved overall survival, 38 months compared to 34 months, so an absolute 4-month benefit with the addition of panitumumab compared to bevacizumab, and we'll have a link to that study as well.
So one of the things that's really interesting about this story between why is side of tumor predictive of response to cetuximab. And what you can see here in that CALGB 80403 study, patients with right-sided tumors tend to have more aggressive disease biology. These also tend to be younger patients, and they more often have a BRAF mutation. So a lot of people thought maybe it's because more of those patients have a BRAF mutation, but it's actually more complicated than that. And it turns out if you look at very detailed molecular analysis of left-sided tumors versus right-sided tumors, they're very different diseases. Those right-sided tumors tend to be more aggressive. They tend to have things that will modify that EGFR pathway and downregulate it, so it's not important for cancer cell survival, which makes sense why these left-sided tumors are responding to EGFR-directed therapies, whereas the right-sided tumors aren't. So it's not just BRAF mutation that's driving this, and I always found that very interesting. So let's get back to the case of our patient. So we have this female with metastatic colorectal cancer, left-sided, RAS wild type, BRAF wild type, not MSI high. To summarize, for a patient like this, not MSI high, FOLFOX or FOLFIRI backbone is standard of care based on that really early study in the late 90s, 1997 to 1999, which says do either one you want first. We dropped the chemotherapy after about 3 months based on that OptimoX study that we talked about, that you don't need to have continuous therapy in several meta-analyses, and continue with 5-FU maintenance. We add bevacizumab for most patients, even though it only really has a very modest benefit and is really shown to be most effective when added to FOLFIRI. And again, in that maintenance setting, so you don't necessarily need to add it to that FOLFOX regimen. And for left-sided tumors that are both RAS and BRAF wild type, we add EGFR inhibitors like cetuximab or panitumumab to our chemotherapy backbone based on the data that Dan just went over. And just remember, when our patient progresses for whatever we chose first, we just switch to the other regimen that we haven't used before. So it's kind of crazy to think, again, that this sequential idea of FOLFOX versus FOLFIRI question that was answered way back in the publication in 2004 still really guides what we do today in our management of these patients. It's a really well-designed study looking at PFS2 as the endpoint, something we should probably do in all of our other cancer types. So for our patient, she got FOLFOX plus panitumumab and tolerated it well other than acneiform rash. Shout out to our pharmacology episode if you want to hear about how to manage that. She was then continued on 5-FU panitumumab maintenance until progression, and then switched to FOLFIRI plus bevacizumab, followed by 5-FU bevacizumab maintenance. And she now asks us about getting a treatment break. She's had so much treatment, and she's doing well. Her scans look wonderful. So what's the data on giving these patients a chemotherapy holiday? And what about retreatment with a prior regimen?
So there's really no right way to manage these patients. And so, as is the art of oncology, we have to individualize this discussion based on the patient. Most providers would argue that a 4 to 8 week holiday is a reasonable amount of time to forego 5-FU maintenance therapy. But remember, we're only talking about a few months of difference in the OptimoX 1 study that we discussed earlier, so breaks are very important and very reasonable. And so during these breaks, we recommend that patients are monitored serially with CEA to determine when to reintroduce therapy, particularly if they've had excellent response to prior therapy. Ideally, in the future, better results and better studies will come out regarding the use of ctDNA in this space to help us determine, which patients to start retreating. But for now, in 2024, in June of 2024, this is not yet ready for the limelight and is only pretty much limited to clinical trial use. So retreatment with a prior regimen is extremely reasonable based on everything that we talked about today. So remember that OptimoX 2 study showed that retreatment with FOLFOX after 5-FU maintenance had a response rate of about 30 to 40%. It is unclear if we should retreat patients who progress while on something like FOLFOX or FOLFIRI in later lines, though there is an ongoing study trying to evaluate this question. So a lot of things to look out for, certainly in the colorectal space. So based on our discussion, the patient took an 8-week treatment holiday to travel, and then she resumed therapy with 5-FU and bevacizumab maintenance. She comes to clinic, and she's found to have progressive disease, unfortunately. What are the options in the later line?
So I really want to highlight what Ronak said there, that when we think about retreatment, we don't want to use the same regimen, at least today, if the patient progressed on that previously. But remember, most of these patients were just dropping chemotherapy to maximize their quality of life. This isn't a sprint, it's a marathon for these patients with colorectal cancer, fortunately, with how we treat these patients today. So in our next episode, we'll discuss patients with MSI high disease, HER2 positive, BRAF mutated disease. But again, let's now focus on patients without these actual mutations. There's a drug called TAS-102 or Lonsurf, which is shown to have some activity in this setting. And most recently, there's a trial called the Sunlight trial, published in New England Journal of Medicine 2023, that looked at TAS-102 plus bevacizumab versus TAS-102 versus with placebo. And there was an improved overall survival with the bevacizumab combination from 7.5 months to 10.8 months. It's important to note that TAS-102 comes with some tolerability issues, including cytopenias and GI side effects. And overall, the drug has very little activity. And this combination regimen showed an objective response rate of only about 7%. And we look at when TAS-102 or this Lonsurf medication was originally approved based on a phase 3 study called Recourse, published in 2015. There was only a 1.6% response rate with a modest 2-month improvement in overall survival. So a lot of people said, really, we need to do a lot better for these patients. Once they progress through your FOLFOX, your FOLFIRI, your bevacizumab, your cetuximab, there's not much left. But fortunately now we do have this TAS-102 plus bevacizumab as a standard of care for some of these patients. Very recently, we also have the approval of a VEGF tyrosine kinase inhibitor called fruquintinib for these patients as well. And this is based on the FRESCO-2 study published in The Lancet of 2023. And patients were included in the study if they had all approved therapies, like I'd mentioned just now, including TAS-102. So they had to have had some TAS-102 prior to enrolling in the study. And they were randomized to fruquintinib versus placebo. There was an improved overall survival of 7.4 months versus 4.8 months, favoring the fruquintinib arm, which led to its approval. Notably, what's very interesting, there were 30% of patients in both arms who received subsequent anti-cancer therapies. And these are patients generally with an ECOG of 0 to 1. And what does this tell us? That we did not have an investigator's choice control arm in either this trial or the TAS-102 trial. And we know, again, think about that Optimox 1 trial. Patients got FOLFOX, then stopped, and then they got retreated with FOLFOX, and they still had a good 30% response rate. So could it be that we're just waiting for these patients to progress, not letting them get chemotherapy when their performance status is optimized? And is that the reason why we're seeing this benefit? Or should we just be retreating these patients with prior regimens if, let's say, their neuropathy has resolved or improved? Or, yeah, maybe they had an issue with irinotecan, but you dose reduce it and try FOLFIRI again. Those are all really reasonable options. And that's really the issue now in the metastatic space in these later lines, is the control arms are placebo rather than an active comparator arm. And we know that at least a third of the patients plus are still getting treatment after they progress on this placebo arm. So it does make you wonder, should we be designing these trials with investigator choice chemotherapy, allowing for retreatment with something like a FOLFOX or a FOLFIRI? And the last thing that we'll mention very briefly, there's another TKI called regorafenib that's approved technically in this setting. You will not see it used by many providers at all. The data is very poor and it's a very toxic drug. So we're looking at something like the Lonsurf plus bevacizumab, followed by fruquintinib, at least what we have today, acknowledging there's very important limitations that we need to address for those trials and future trial design.
That's great. And Vivek, I think it's really important that you highlighted some of those limitations of these studies, because these are important considerations that we need to have. I mean, I think that we have certainly made a lot of progress in the management of colorectal cancer, but I would argue that a lot of these major treatments have been in the earlier setting, in the earlier stages of disease, and there's still a lot of work to be done in the metastatic setting. I mean, with the exception of FOLFOX and FOLFIRI, many patients are not deriving very durable benefit from the use of some of these later line agents. So hopefully, someday in the future, we'll be in a better position where we have drugs that can certainly provide a more durable response. But guys, I think that this was a fantastic review. I'm looking forward to the next episode where we talk about some of these more targeted approaches, because these may be what we were looking for, at least for that small subset of patients that do have these mutations, to derive long-term meaningful benefit. So that's all we have for today. Until next time, we'll see you all later.
See you later.
Peace.